Hello everyone, my name is Chang Sun and welcome to Women Data Science 2022 Maastricht Conference video series. On March 8, 2022, thousands of participants gathered around the globe for the Women Data Science Worldwide Conference. In this video, Dr. Mirella Popa, an assistant professor at Maastricht University, will introduce assistant professor Dr. Rianne Fijten. Dr. Fijten presented the first tech talk on that day on the topic of opportunities and challenges in data science for healthcare.
Our next speaker is Dr. Rianne Fijten. She's an assistant professor at the Clinical Data Science Department at Maastricht University. She did her PhD in, she built AI models to diagnose diseases based on biomarkers, and then she continued with developing clinically relevant systems to aid decision support systems for patients and professionals. And of course, she evaluated these in a clinical setup and tested their effectiveness. So we are really looking forward to listen to this talk about the opportunities and challenges in data science for healthcare.
So what I wanted to talk about today is opportunities and challenges in data science, also in healthcare, like the previous one. Later on, I found out that I was assigned a tech talk, but I was a bit bold and decided to make it sort of a tech and implementation talk instead. So I'm not going to solely focus on building models or how to develop them. I think most people in data science are very well aware of how that works. But the implementation side is a very interesting one and not always addressed enough, in my opinion. So when we have a patient, we collect about 80 gigabytes a year per patient in healthcare. And that contains stuff like demographic information like age or gender, but also clinical information. For example, in my case, in oncology, which is a field I work in, you can think about the clinical stage of the tumor, the location of the tumor, all those kinds of things are also always stored in electronic health records, which are the EHRs. But also medical imaging, as was discussed previously in the previous talk. A lot of imaging is generated, especially in oncology. But yeah, if you think about it, 80 gigabytes per person per year, and considering how many patients are in the healthcare system across a year or throughout a year, it's a ridiculous amount of data that we can do stuff. So there are many opportunities for AI, right? Because this data can only be used properly when we use AI. So some of the opportunities that I see with AI in healthcare is in prevention, where you can think about infection prevention, which was a big thing with COVID as well, but also identifying at-risk individuals for chronic diseases, but also stuff like cancer. And for diagnosis, this is something I worked on in my PhD. You can diagnose cancer, for example, with biomarkers or with clinical data. You can also do the same for heart disease or chronic diseases that you can detect early and then treat early. Treatment is also one part where you can really use AI to personalize treatment, but also to predict treatment outcomes and to influence decision-making, right? Medical decision-making. If we know what is going to happen, we can personalize your treatment in such a way that your life will become better, right? Your quality of life will improve, hopefully anyway. So this is a field I currently work in mostly, right? So I'm affiliated with Maastricht Clinic, which is a clinic that treats cancer patients. We don't do the diagnosis, we don't do the prevention, but when patients get sick, they are referred to us for irradiation of their tumor. And this is where we mainly work, right, in the treatment area. One example of this in the research I've performed is preference-sensitive prostate cancer, which means this is cancer that people don't die of. It's well treatable, but they have multiple options to pick from, and those options don't really influence the survival rate of these patients, which means they can select a treatment that fits their life best. But how do they do that? Well, so we built a decision aid for these patients that contained things like information about their disease, information about their treatment, but also figuring out what is important to their life to see if, let's say, a person likes to cycle, then they probably don't want to undergo surgery because that would really have an influence on their stamina to cycle. So those are things you can include in a decision aid and help patients then decide which treatment is best. What we added to that with AI is actually to predict the side effects of those treatments. So let's say a patient gets surgery for their prostate cancer. What side effects will likely happen in the future? And those things are not necessarily included yet in decision aids and stuff that we actually use for medical decision making. And that is something we built with this decision aid. I'll show you an example after this, where we actually used AI to predict the personal risk of this patient, of this individual, based on earlier characteristics at diagnosis. So in this case, we had made a decision aid that included 2 models. Both were logistic regression models because doctors don't like black boxes, which was already mentioned before, and I'll show you later as well. We used recursive feature elimination to actually select a subset of items that would actually be good predictors of our outcome. And we used the 1-year outcome post-diagnosis of certain side effects that we wanted to predict. And we externally validated these with the tripod 3 study. So we had an external validation that was separate based on location. We did this for erectile dysfunction, which is when men can no longer get an erection to have sex, basically. And we had an AUC of 84% in the external validation set, which is really high. This data set was based on about 800 to 900 patients with prostate cancer across the country, across the Netherlands. And we did the same for urine incontinence, which means that they cannot hold their pee, so they pee their pants basically, so they cannot hold it in long enough to actually go to the bathroom, which is obviously something that really affects your quality of life. Most people can probably live without sex, but obviously, if you want to go to the store and you pee your pants, that's not ideal. So this is also a very important side effect that we need to be able to predict in order to choose treatments that affect the quality of life of these patients as little as possible. And for this one, we had an AUC of 0.8, which is also really good. And this was also in the external validation set. On the left, I have written down the preprint that we have published. That one is already submitted to a peer-reviewed journal. The other one we're still writing. We're hopefully going to be able to finish that one in the next couple of weeks, and then it will be also out for preprint. This is what the decision aid looks like that we actually built. So here you can see what it looks like for the patient. It's basically a website with information about the disease. But what we added to this one is a list of questions. So for example, here, it's obviously in Dutch, so it's hard to read for the non-Dutch speakers. But the first question, the first red sentence that you see basically asks, what is the T status of your cancer? And then you can say, as a patient, you can say, okay, I have T1, I have T2. And based on that information, they then go through more information that they would need to make their decision. But then at some point, they end up with these things. And these things then show the outcome of the prediction models. So what you see at the top, it says erection problems, which are the erectile dysfunction problems. And they then get a visualization with 100 puppets. And it says here, 4 out of 100 men like you, right? So people with your characteristics will not be able to get an erection if they want to. So that means that certain treatments, right, that have influence on erection will probably not have an influence on this person specifically based on the model. But for example, this person would have problems with incontinence, right? Because you can see all the puppets in the second visualization are red except for one, which means that 99 out of 100 patients with their characteristics would get incontinence issues. So then you would say, okay, let's not do a treatment that would cause more incontinence because you're already at high risk for incontinence. Aside from that, where we developed this thing, but now we run into issues, right? Because the technology is generally not the issue. We run into issues where we actually want to implement it due to a lack of integration in care paths if you don't consider these things early on in the process. But also things like low health literacy and digital literacy, which is how much patients actually understand about their health, but also about digital tools. Can they even use digital tools, for example? And there's also a lack of trust in AI by doctors and by patients. And I think this is also a very important thing. If they don't trust it, they're not going to use it. And this is a crucial issue, right? If we can build AI models, perfect. But what if it stops there, right? What if we cannot go and take this next step to actually get it into the clinic? And this is something a lot of people underestimate, in my opinion. The findings I'll show you here are based on qualitative research performed by a former PhD student of mine, Anshu. I don't know if she's in the call, we'll see. She is now a postdoc in another group, but she did a lot of qualitative research where she actually talked to doctors and patients to figure out what they actually think about this stuff. which is really interesting. So it's not quantitative, but it is qualitative. So, for example, problems with the integration and care plots is that we usually run into issues with doctors saying, we don't have time to include AI, right? We already have so much to tell patients during a consultation. How are we going to include the AI? How are we going to explain what this AI does and what they need to consider actually by using it? And also, they don't want to fill in these variables, right? So this means you need to integrate it somehow with their existing systems. This is also usually very difficult because these existing systems are different per hospital. So usually you need a tailored solution for each hospital. One of the quotes that we got from this qualitative research is as follows: if you have a model in which you have to fill in 13 variables in order to get a result, that's a hindrance, AKA I don't want to do that, right? So we need to come up with a solution to reduce this threshold. And another one is that doctors are worried about making decisions based on transient effects, aka effects that go away over time. So what if you build a model that predicts a side effect, but this side effect goes away after 6 months, right? Is that valid enough to do decision making on? And those are also concerns that doctors have. And for that, I think the solution for that would be to actually include doctors in these processes. With low health literacy or digital literacy, we run into issues that how are we going to actually explain this to patients, right? Even regardless of whether we have the time or not, how are we going to explain it that they understand? And also extreme predictions, for example, telling a patient that they have 100% chance of dying within 6 months, right? Which can happen in oncology. This can induce a lot of stress in these patients, right? So, and you don't even know if this is actually going to happen because models are never 100% correct. But also if you have the opposite, right, where you have a middle ground prediction that says, yeah, you have 50% chance of dying within 6 months, then there is no basis for decision making. So these are really crucial things that I think we as the builders don't necessarily consider, but they are very important. And then there's the trust, which I think is a very big one. A lot of doctors have concerns about privacy, right? So how can I ensure my patient's privacy when using these models? Are their data stored anywhere? Who is accessing them? Who is doing what with them? But also black box models. What is the model doing, right? How can I be sure that it's doing what it's supposed to be doing? And there are also quite a few concerns about statistical stuff, right? Like carrying out studies that AI models are built on that are not multi-center studies, right? So how reliable is that? Also, if you don't do appropriate external validation, how valid is that? A lot of doctors, at least that I've spoken to, are unwilling to use any AI model that is not externally validated, which is a very crucial thing because a lot of AI models are not validated. So this is a very important thing to consider if you want to put something in the clinic. So what can we do then? Right, a couple of things I've already mentioned while talking, but I think it's very important to consider when we are building these models to also consider how we are going to actually introduce them into the existing infrastructure that is already there at the hospital, right? So, for example, if you have an EHR system at Maastricht, you need to build an AI model that can communicate with the EHR system so that the doctor doesn't need to open, like, I don't know, an extra field in the computer, or they have to have another program installed on their computer. They're not going to use it if it's not integrated with their existing systems. So if you do this integration, and I know it's difficult, but it's crucial, you will reduce the usability threshold. That means more people will be able to use it and will use it because it's less work for them and it just is integrated with their entire system. But we also need to educate people, right? Not just the physicians, but also the patients in order to improve the health literacy. You can think about workshops for doctors or awareness campaigns for patients. And those will hopefully increase then the literacy and the ability for patients to understand what they're actually doing. And, you know, considering that we actually a lot of people want to input AI into the clinic, I think this is crucial, right? If we're going to influence decision-making, we need to make sure that patients are actually understanding what is happening. Statistically speaking, if we look at the trust issue, I think we need to work on external validation and more multi-center studies, just to make sure that doctors and patients actually trust that the model works as it's advertised. And then the most important thing, in my opinion, is to address a clinical need. There are too many cases where we think we know what patients and doctors want, and that is not the case. I've experienced that myself. The side effects we chose for this decision aid were in consultation with doctors, but not with patients. When we were 2 years in the project, we found out that patients actually weren't that interested in one of those side effects. They were more interested in another. And then we couldn't back out anymore. So we decided to continue with it. But it does illustrate that it's really important to actually talk to your patients and your doctors to really figure out what do they need, right? What are their needs in this care path or in this disease that they have? And that will, obviously increase their involvement and also the clinical applicability then. So I think my take-home message from this talk is very, very generic in that sense, that the technology is not necessarily the issue. It's the implementation. We can build so many models, but if we don't think about the implementation in the clinic, there is no point. We could easily just stop building models because we've built enough. So I think it's really important, if you are building models that have some use in healthcare, that you really consider implementation as well and talk to patients and doctors. That's all I wanted to say today. Thank you.
Thank you for watching this WIS Conference 2022 video from Maastricht. And you're welcome to watch more conference videos from WIS worldwide on YouTube. Please keep watching.